Policy Committee, and it is Thursday, February 19th, 2026. And we do, I believe, have a quorum present, although we are not taking any votes today. Before we start, I just would like to go over just our committee expectations, and this is not anything dissimilar from last year, but just to make sure that members of the public and our committee have these expectations for how the committee hearings will be run. The Senate, we do have a policy that there are no signs allowed in our committee hearing rooms. Outbursts and clapping and cheering, loud noises are not part of our committee tradition or allowed in the hearing room. We will have I think a new feature this year in our committee hearing rooms of these stanchions with the barriers that limit access, and they're meant to define the area which is for members and the committee staff and committee, all of the members of the Senate staff to be at the hearing table. If you do have a need to speak with a member, members can step outside and conduct meetings if that's necessary, or you can set up meetings outside of our committee hearing time. So I just want to make sure that people are aware that is in place this year and is something new for our committee room structure. We will be continuing our policy this year of having hybrid hearings. We do have the ability for testifiers to appear remotely, and that will be handled with the help of the committee administrator. And then just as many things have happened, and since our last committee hearing, since we adjourned our session, since we completed our special session in June, we do have one change in our committee membership. Senator Fate is joining the committee, and Senator Hoffman has stepped away from the committee. Senator Fate isn't here yet, but we will, if he arrives at a time that we can have him introduce himself to the committee, we will do that either today or our next meeting. I'd also like to give an opportunity. We have 2 new pages for our committee room this year, and if they would please come forward. And if you could step to a microphone and introduce yourself for the committee. Thank you.
My name's Brooklyn, and I'll be a session committee page.
I'm Finian, and I'll also be a committee page.
Thank you, and welcome to our committee. Next, as I mentioned, a lot has happened over the past months since we were here to finish our special session in June. And today's hearing is meant to help us understand the significant and widespread impact of federal actions on health and human services in Minnesota. We've seen impact on our providers, our counties, and most importantly, impacts on the people we serve. Over the course of the past year, but especially the past few months, we have seen cuts directed specifically at Minnesota, disrupting critical services in our state. These are not abstract line items on a spreadsheet. These are dollars that support medical assistance, that feed kids and families, and that fund behavioral health programs for children and public health grants, along with funding services for children and seniors. Over and over again, federal officials are recklessly taking action via tweets based on debunked viral videos, conspiracy theories, or political retribution. The administration has offered little to no clarity for these threatened cuts, leaving providers, families, and the state in limbo. We are also here to talk about the federal budget bill, H.R. 1, and what it means for Minnesota. While framed as a federal fiscal measure, its impacts are felt squarely at the state and local level. H.R. 1 shifts costs and responsibilities to states and counties. It increases administrative burdens, and it reduces federal participation in programs that Minnesotans depend on. Our state is home to some of the best healthcare systems in the world. H.R. 1 has put that care at risk. Because of H.R. 1, health insurance costs have already skyrocketed, and those rising costs threaten the stability of family economics. While we will do what we can to protect affordability and access, our state alone cannot make up for these federal decisions. When federal commitments shrink, the need does not shrink with them. The burden shifts. It shifts to the state budget, it shifts to county governments, and ultimately, it shifts to property taxers and to families trying to navigate already complex systems. Counties are the frontline administrators of many of these programs. They handle eligibility, crisis response, child protection, economic supports, and services for people with disabilities and older adults. When federal support becomes unstable, counties are left managing demand with fewer predictable resources. They're forced into impossible trade-offs, and that is not sustainable. We must also address the impact of increased activity by U.S. Immigration and Customs Enforcement and the impacts it has had on people, children, hospitals, and our health. Families are avoiding clinics and hospitals out of fear. Parents are hesitant to enroll their children in programs they qualify for. Preventive care is being delayed. Mental health providers are reporting increased trauma and toxic stress among children who fear family separation and whose friends have disappeared. When families are afraid to seek care, health crises do not disappear, they escalate, and the long-term costs, both human and fiscal, grow larger. Schools are feeling it, public health agencies are feeling it, and emergency rooms are feeling it. What we are seeing is a cascading effect: federal funding instability, policy shifts causing skyrocketing costs, enforcement actions that create fear in communities, all converging on the very systems designed to keep people healthy, safe, and stable. Today's hearing is about that full picture: the fiscal impact, the operational strain, and the human consequences. It is about hearing directly from those administering these programs and those affected by these changes. It is about accountability and about ensuring that Minnesota families are not collateral damage in federal decisions. Our responsibility as policymakers is clear. We must understand where the pressures are building. We must assess the long-term implications for our state budget and our counties, and we must determine how we protect Minnesotans and preserve the integrity of our health and human services system. And now I'd like to move to our first testifier, and we have Anna Mingy here to present from the Minnesota Management and Budget. And members, since this is our first hearing, this is really the beginning of our discussions about the impacts of what you're going to hear about today. We have a very full agenda. We have many testifiers present who are going to be talking about the different impacts. And so I would ask that you hold your questions, and we will see if we have time for a discussion or questions at the end. Specifically related to the MMB presentation, this is an initial presentation meant to cover all aspects of the areas that affect our committee, but it is a beginning discussion, and even next week we will begin to have presentations by the agencies, the specific agencies that are in our jurisdiction. And so I would ask that you make note of your questions, and then we will be able to have discussion about any of the topics that are brought up today. With that, Ms. Benke, please state your name for the record, and you can begin.
Good morning, Madam Chair, members of the committee. I'm Anna Mingy, State Budget Director with Minnesota Management and Budget. Thank you for having me to your committee this morning. This is a topic that we have been spending, as you may imagine, a significant amount of time on and is really important, especially important to the delivery of health and human services in the state of Minnesota. As Chair Wickland mentioned, there have been significant changes in federal funding affecting this committee since since the legislature adjourned back in the spring. And we're going to cover some of those at a high level, focusing on both some changes from the congressional level as well as some pressures we're facing from executive branch decisions. I'd like to start by just showing a visual of how important federal funds are to the state budget. About 36%, or you could think, $1 in $3 that state government spends actually comes from the federal government. So if you think a total budget of about $133 billion, 36% of that is coming from the federal government this biennium. So our services are highly dependent on resources from the federal government. But on the next slide, you can see that in the health and human services space, that is even more important. More than half, almost 60% of the spending in the health and human services area is coming through federal sources, largely, as you might imagine, federal entitlement programs like Medicaid, child care, economic supports, but also important programs in the public health space, among many others. From a budgetary perspective, we look at the federal funds supporting state programs in terms of whether they're supporting state-level entitlements or whether they are sort of programmatic, sort of isolated from state-level entitlements. And the reason that that is important is that if a federal funding source is supporting a state-level entitlement, if the federal funds go away, then the state budget sort of automatically fills in the hole. And that means that a loss of federal funds results in increased costs to state government. If we look at just 2025, about $15 billion, or about 2/3 of our federal awards, were supporting entitlement spending. And of particular note to this committee, that includes Minnesota's medical assistance program, most is the largest among those. So moving to specific changes, I'd like to talk about the Federal Reconciliation Bill, which I'll refer to as HR 1. Others call it you may hear it referred to as the One Big Beautiful Bill Act. The HR 1 was signed into law by the president on the July 4th. It has really significant impacts for taxes, healthcare, nutrition programs, among other areas. At the time it passed, the CBO estimated the bill would cost about $3.4 trillion over the next 10 years to the federal budget, sort of increasing the federal deficit. That represented about $4.5 trillion in net tax cuts, offset by $1.1 trillion in net spending reductions. Since this passed, state agencies have been analyzing the impacts of the law to Minnesota, our federally funded programs, and our state budget. But I want to just provide a caveat that the estimates that we're going to talk through today are based on the best information analysis that we have at this time. There are still places where we're waiting for federal guidance, and that will change the costs associated with some of the provisions of the law. Before I talk about the budgetary ramifications, I want to provide an overview of some of the changes specifically relevant in the health and human services space, in both healthcare and nutrition programs. So starting with healthcare, the Federal Reconciliation Bill enacts sweeping changes to the Medicaid program, ranging from impacts to enrollee eligibility, to providers and county workers, and to impacts on the state's financial stability. So one way that it affects eligibility for enrollees is to establish work reporting requirements for adults without children. It also makes changes to eligibility for legal non-citizens. I should note that this is not by any means an exhaustive list of the changes in the bill, just highlighting some that have specific and significant fiscal impacts for the state. There are also impacts on our providers, such as limits on retroactive coverage, sort of the services that the state Medicaid program will pay for prior to an individual being found eligible for medical assistance. And there are limits on directed payments that can be made to Medicaid providers through medical assistance, drawing down federal funds. In terms of impacts to financial stability, there are limits on provider taxes, which are an important source of financing for the state Medicaid program, as well as the creation of new state penalties for payment errors in the future. Another impacted area is SNAP, the largest federal nutrition assistance program. It stands for Supplemental Nutrition Assistance Program. HR 1 makes changes to eligibility, which state agencies estimate could impact the 440,000 participants in the program. For example, it expands work requirements for adults without dependents. It also changes benefit levels, meaning that those who are eligible may receive a reduced amount due to the way that USDA calculates and sets SNAP benefits. It also impacts state and local financial resources. The first major change includes a new matching fund requirements, also known as cost sharing for SNAP benefits, which is significant as this has historically been a 100% federally funded benefit. The change also requires states and local governments administering the program to double the non-federal administrative share for administering the programs. And these impacts take effect over the period October 1, 2025 through October 1 of 2027. I like to think about the ramifications of these changes for the state budget in three main categories. There are some that will automatically impact the state budget. You can think of these as things that have been included in the November forecast or might be included in future forecast. There are also provisions where the state will be required to make the changes, but it is not an obligation under current state law, and so additional appropriations are required and legal authority is required from the legislature. And finally, there are significant losses of federal funds that create pressure on our state programs and on our community partners, for which policymakers will need to decide to what extent and whether we provide additional appropriations to mitigate those significant pressures. So with that, we can actually talk some about the estimates of lost federal funding as a result of HR 1. And what you're seeing here is an estimate by state budget biennium. So we have 2026 and 2027. The lines to the left, or the bars to the left of the dashed line, represent the total fiscal impact. And the bars to the right of the dashed line decompose that into sort of how they are affecting sort of who is experiencing the loss of federal funds. So we estimate that in 2026 and 27, the state will receive $327 million less in federal funds, and that number grows to about $1.6 billion in the 2028 and 29 biennium. If we had a bar for the biennium beyond the forecast horizon of 2030 and 31, it would be in excess of $2 billion. So if you move to the right of the dashed line, the first set of columns refers to the automatic cost that results from the passage of the law. Generally, you can think of these things as things that appeared in the November budget forecast. So they are things that the budget outlook has already accounted for. And this represents about $223 million in the first biennium and $480 million in the second. The two columns to the right of that reflect costs the state needs to fund in order to comply with changes under the law, but that are not automatically reflected in the budget forecast because the legal and sort of appropriation authority doesn't yet exist. That's $12 million this biennium and $195 million in 28 and 29. I'd note the largest cost driver there in the out years is the new state share for SNAP benefits. And then the two columns to the farthest to the right, the first, lost federal grants. These are places where the federal law sort of eliminated grant programs. It creates a loss of federal funds to the state, but the state is not required to fill in the gap. And then finally, on the far right, those impacts to other entities. This represents lost funds most significantly to our hospital system as a result of lost provider taxes and directed payments, but also lost coverage to beneficiaries and impacts to counties who you all understand are important partners in the delivery of human services across the state. So next I'll pivot to a discussion of some of the executive branch changes that we have experienced in the last several months. Most recently, the Department of Health received notice of termination of 2 CDC grants. We received the notification last week, as well as the intent to cancel 3 more. The largest of these grants is the Public Health Infrastructure Grants, which was a $65 million award. The terminations, sort of if they were to take place, would make significant cuts to local public health, tribal health, funds to monitor HIV and STD infections, as well as funding for a significant number of employees within the Department of Health. Last week, there was a multi-state lawsuit that resulted in a 14-day temporary restraining order pausing the termination, and that was extended so that it goes through March 12th, 2026. So this is something that we're monitoring. We do not know the outcome, but as of right now, the cancellation is on hold. We've also received significant federal communication around a number of funding sources from the Administration for Children and Families, which placed several significant grant programs under temporary administrative review earlier this year. These are funds that you are likely familiar with, the Child Care Development Block Grant, which provides funding, the federal funding source for the state's Child Care Assistance Program, as well as a number of other supports to the child care sector. The TANF Block Grant, which provides the federal source for the Minnesota Family Investment Program, as well as a number of other supports for low-income families across the state, as well as the Social Services Block Grant. These cancellations are also on hold as a result of a preliminary injunction. But if we were to lose federal funds in this space, it creates both pressure on the state budget as well as pressure and impacts to our community and to families across the state. Both the Child Care Development Block Grant and the TANF Block Grant pay for both state-level entitlements as well as non-entitlement services. And this is an example of if the funds went away, there would be both an impact to the general fund as the state needed to backfill that portion of funds. And then there would also be just a loss of services and grants to providers across the state, across a number of programs. The table on this slide, it sort of tries to break those impacts apart. So you can see within the Child Care Development Fund, the entitlement share, the MFIP Child Care Assistance Program, we have about $33 million of federal funds yet to draw this fiscal year and $123 million next fiscal year. So if this funding source went away entirely, the state budget would need to find another $156 million for CCAP this biennium. Similarly, the TANF Block Grant has about $52 million for MFIP yet this year and $127 million next year. So that's about $179 million of federal funds yet to draw this biennium. That creates a risk to the state budget. But there are also really important programs that are funded by these sources that do not have that automatic linkage to the general fund, which the state agencies and policymakers such as yourselves would need to grapple with what happens in the absence of federal sources. So finally, I'd like to touch on another significant risk that we are monitoring. On January 6th, CMS, which stands for the Center for Medicare and Medicaid Services, which is the federal agency overseeing Medicaid programs, indicated that they intend to withhold $515 million per quarter in future federal funds. That was their estimate of the federal share of 14 high-risk services based on data from the previous year. This withhold has not yet begun. We don't know when it would begin or when it would start, so it's really challenging to estimate the magnitude of risk here. Obviously, if, on an annualized basis, $515 million equates to about $2 billion a year. This federal funding is theoretically something that could be returned if the federal government was satisfied with our corrective action plan and if our Department of Human Services demonstrates that those claims are valid. And DHS has submitted an administrative appeal, which is currently pending. CMS has indicated it will also undertake a review of recent claims for which we have already been reimbursed, and that may result in a deferral of additional federal funds. Again, the scope and timing and resolution of that review is unknown. So in the CMS space, there is both a prospective potential loss of federal funding as well as a retrospective review that may occur, both of which create significant rate risk to the state budget. So as I've stated, the reason this creates a state budget risk rather than like an automatic impact to services is that for most federal state funded forecast programs, reductions in federal funds trigger increases in state spending. That's different for non-forecast programs where there are losses in services that create budget pressures but don't automatically drive an increase in state spending. And to contextualize this in the scope of the current budget forecast from last November, the general fund had a projected balance of $2.465 billion this biennium. So that budget surplus this biennium, but a projected negative balance of almost $3 billion next biennium. So because we don't know how much money we would lose or when it would happen, we can't say precisely how we would manage those losses, but I think it's safe to say that if we had a loss of federal funds above $2.465 billion this biennium, we would need near-term action to balance the budget. And policymakers would need to be involved in how we make those choices. But regardless of when the funds, if we lose funds, regardless of when that occurs, any reduction would worsen the current shortfall that we have in 2028 and 2029. So although we have a surplus right now to help mitigate against losses in the current biennium, if we are relying on that surplus to carry forward into 28 and 29 and mitigate the shortfall that exists there today. So if we lose funds, whether it's this biennium or next biennium, it means a bigger problem for us to solve in the future, which might result in losses of services to Minnesotans or a need to find solutions elsewhere. So with that, Madam Chair, I'm happy to take questions if you feel it's appropriate at this time.
Thank you, and Ms. Mengi, and when I introduced you, I neglected to say you're State Budget Director, and I appreciate your being here. Next week, we will hear from individual agency, budget, and agency folks. Are there any really brief questions before we move on to the next presentation? Senator Abler.
What look was that, Madam Chair?
That was the really brief question.
For the future, no, I was trying not to ask a question, but there's one that would be helpful to clarify. And I don't know if anybody knows the answer, but on the one about this estimates of federal loss funding,
The slide with all of the
Yeah, so
bar.
that, and I can just get it for later, but like which of these is money we have now and which of these is money we didn't get? And I don't need an answer now because I know we're short of time. And that would just be helpful to me. Thank you.
And Ms. Mengy, does that question, do you have the understanding of the question and how we might get more information on that?
Madam Chair, Senator Abler, I think we can provide the specifics. Many of these changes to the effect, or to the extent that they're taking effect in this biennium, some of them started last October, and then others are sort of rolling. So we can, largely they are funds we are losing sort of in the future as a result of policy changes. But in some cases, they are things that we are already experiencing, but we can follow up with specifics.
Madam Chair, just to be really brief.
Senator Abler.
Like there's some things in the budget that we passed last year that I thought were not going to happen and didn't happen. So if you can just clarify, if any, is it that sort of stuff? Like the counties are worried about more increased costs, so that's a topic. But if there's something that they were hoping to get that never came true, that we passed, that was aspirational, that's all. I'll let it go at that. Thank you, Madam Chair.
Thank you. Senator Otke.
Thank you, Madam Chair. And just to kind of add on a little bit to what can be a follow-up as far as information we get back from what Senator Abler was talking about. But as we went through some of these lost grants and various things, if we could find out what grants are just, they're gone because of the HR 1 and the changes at the federal level, and what grants are we not at this point looking to receive because either we haven't complied or we need to adjust so that we follow the CDC best practices so we would then be in compliance and get the money. So if we could find out which ones are going to be totally gone and which ones we have the ability to recapture if we just change our policy.
Ms. Mengy, if you could take that back to the departments, I guess that would be helpful. Thanks.
Yep, I will follow up with the committee, Madam Chair.
Okay. Thank you. And now I'd like to move to the next presentation is from our county's perspective. We have Matt Hilgart, Barb Dahl, and Garrison McMurtry. Welcome to the committee, and I'll let you get your presentation set up. Welcome, and if whoever wants to go first, if you could please state your name for the record and begin your testimony.
Thank you, Madam Chair. Good morning, members of the committee. My name is Matt Hilgart. I work for the Association of Minnesota Counties. AMC represents all of Minnesota's 87 counties. It's good to be here with you this morning. I'm joined by Barb Dahl, who is the Human Services Director in Scott County, and Commissioner Garrison McMurtry, Commissioner from Ramsey County, as well as our colleague Angie Teese, who will be here in case there are questions and we need her technical expertise. Madam Chair, I also wanted to thank you for the introductory remarks. It did a good job of encapsulating both the fear that local governments are facing right now, but also recognizing the critical role that we play in administering social safety net programs in Minnesota. And as you've started to hear through MMB, and you hopefully will hear through us, there is a cacophony of issues that we are facing at local governments, and the question just seems to keep coming back in boardrooms of how do we even take a bite out of all of this. And I hope this presentation will just demonstrate the tidal wave that is in front of us at this moment. I appreciated Ms. Mingy's presentation because, like her, it's hard to consolidate some of the impacts of HR 1 into broad areas. And Ms. Mingy and her team has been doing a great job of trying to communicate everything that the state does know and doesn't know through webinars to local governments, outreach, presentations, et cetera. HR1 has vast implications across a variety of areas. And today, the issues that our team is going to focus on presenting really impacts, we're trying to focus on the impacts to county operations, and through that, county clients, county residents, county property taxpayers. I say potential impacts because this legislature has decisions to make. And just as Ms. Mingy stated that some are governed by law, some there's a lack of clarity. Here too, there's a lack of clarity on who will pay. And this is something that we are already in conversation with legislators, but will be something that the legislature will have to consider this year. The first category on this, the first block to the left, is probably the easiest to explain. And that is just simply the federal government is going to reimburse us less for doing their mandated work on a federally mandated program. Right now in Minnesota, counties pay 50% already of the administrative cost to administer SNAP. So let's get that straight. A federal food benefit mandate that they turn to the states and say, you have to administer this. Here in Minnesota, the state turns to us and says, can you administer this? And we're already paying via property taxes 50% of the staff time, resources, et cetera, in local community to administer that benefit. Potentially, that shift would mean, hey, we're gonna cut that 50% by another 50%, and you'll be left with 25%. So that is a direct cost shift, no questions about it, to potential property taxpayers if that is allowed to pass through to counties, which we are hopeful it won't be. The second, and I want to note here too, Minnesota still stands, I mean, whether it's child protection, social safety net services, or the administration of SNAP, we're actually one of only 3 states that has any kind of county cost share on the administration of this program. So there is already a heavy property tax reliance on administering SNAP program locally. The second is the increase, and this is more nuanced, but significant as well. And this is the policy changes that are both in SNAP regarding eligibility, changes to work requirements, as well as the work requirement for Medicaid for certain groups of individuals. And this one, tugs at our membership too. We represent 87 counties across the state. You can imagine the variety of political thoughts, theories, et cetera, across those memberships. Some folks are prospectively saying, okay, why not have these requirements? Others are against them. But what is not up for debate is the administrative time that it will take to administer these work requirements. For Medicaid populations, it is a new reassessment every 6 months, redetermination. That means a doubling of the caseload that we're already doing for those populations. And when we say doubling, that may sound, hey, counties, just buck up and you can do that. We'll get to a slide here and you'll see why that isn't really possible and why it actually means counties are levying dollars right now, even during property tax crisis, just to hire people to do this eligibility. So it becomes a value question as well. Do we really want to be spending limited levy dollar resources on hiring more eligibility workers to do policy things, or do we want to be helping in community? These, as you can see, go in effect into different times, but the Medicaid one is the largest one, and that will be January 1st, 2027. The third one has the largest, and this is on the far right, the dark green screen. This has the largest potential impact to the state and hopefully not local governments, but a concern that we very much come to this legislature talking about, which is hopefully not passing this liability down to locals. This would be, as Ms. Mingy mentioned, would be the first time that we are saying as a country that local states and potentially local governments would be responsible for the SNAP benefit, for a cost share of that. And they do this through what's called an error rate. And I would argue this error rate is a misnomer. We'll get into this shortly here. But that is the mechanism that could mean that states are liable for either 5%, 10%, or 15% of the total cost benefit of the SNAP program. The thing that really gets me here, and you can see probably from my facial expressions, I don't have a good poker face, is the caveat that, hey, if you have a high SNAP error rate, you're going to get penalized more. And again, we'll go into why this isn't logical and why the error rate is a misnomer. But we're only going to penalize you up to a certain amount. But for those states who are really egregious, you guys get a pass for 2 or 3 years. So again, Minnesota is not so good that we don't have a SNAP error rate in these runs, but we're also not so egregious that we get this exemption that the federal government provided for certain states. So that's something that obviously we are going to Washington and trying to lobby on, but is something to consider here. The number that I put up here, and we will see different numbers because it's all fluid, but right now, based on our 2024 numbers, this could be a cost shift to the state of $86 million. And we are right on that precipice of going up to the next category of that 10 to 12% error rate. So if we hit that one, that will be, I think, well over $100 million a year in potential cost share on this program. And I'm going to zoom out just for a second because it's a privilege to be before you, first of all, because I think this is my first time ever in front of the Health and Human Services Committee. I am usually found in the Tax Committee or Elections Committee. But I will say for the folks who have been interested in kind of property tax discussions, this all matters because property taxes aren't just a bill. They're also a set of values for each county. They're a set of limitations, but they also affect every single person, not just homeowners. Remember, if you're a renter as well, those bills are passed through, the property tax bill is passed through to renters. And so what's important here is that the state of Minnesota is coming off its highest average levy increase, highest average property tax increase in over 25 years. For counties, the average county property tax was over 8% this year. That is not, we are very fearful that that is not just a blip, but a very concerning trend. And HR 1 does not help in any of that regard. And the last screen I have for my presentation is one that hopefully you all have seen. You're familiar. I come bearing gifts. I brought one of our most recent magazines. Chair, I very much appreciate the time that you've lended to this. Senator Utke, you've seen these presentations. Chair Port, you've seen them too. And I think Chair Abler could probably give this presentation himself. But that is of the green screen that we have. And obviously technology does not have a soul, but it affects individuals. It affects humans. And these, you're looking at the systems that our hundreds and hundreds of county workers across the state are doing. When someone comes in need and goes to the MN Benefits portal and submits a SNAP application, it looks great. It's online. You can access it through their phone. They're submitting that. It might take 20, 30 minutes, and they submit it. And they think government's going to take care of it. This will be processed. What we do is we print out a PDF of that benefit because the systems don't talk to each other. We put it in front of our screens at a county office and we type in all the information that person has entered. That's the first 15, 20, 25 minutes. And again, that's when you're proficient after being trained for 2 years on these systems. Then we manually do overrides of the system itself. Sometimes when we're determining cash benefit, sometimes when we're just doing address changes because it doesn't automatically upload addresses. Suffice it to say, what this means is that your county workers, property taxpayer funded, are spending countless of hours each day on duplicative steps, the eligibility systems of these systems, and trying to get folks benefits. It means that residents are frustrated because they don't know where they are in the queue of getting their benefits that they need and that they're entitled to. And it means that we are sitting here saying we can't take on more. And obviously we're talking about the fact that HR 1 is requiring us to take on a tremendous amount more. And so I want to leave you with the idea that obviously we need to have a conversation about where some of these cost shares are going to be going. But one thing we cannot wait for any longer is an update to these systems. For whatever reason we want to look at it, whether it's for the clients' access to these quicker, for the workforce that we're losing and can hardly hire because they look and say, why would I want to do a functioning COBOL or DOS-based system, or for fraud mitigation as well. Any lens that you look at it, modernization is the answer, and that's what we will be coming to the legislature with as one of our top priorities this year. And with that, we're going to transition to Ms. Dahl, who will be talking a little bit about the misnomer of the error rate.
Thank you, and welcome to the committee, and please state your name for the record, and you can begin.
Yeah, good morning, Madam Chair and members of the committee. My name is Barb Dahl. I'm the Health and Human Services Director in Scott County. And again, we appreciate you taking the time and letting us go into, I guess, a little inside baseball on what really makes up the payment error rate. And so if we were to just take Scott County, for example, and we go back to 2024 and look at what made up our payment error rate, you would probably want to know how many clients did we actually serve, how many cases. We had around 4,000 cases that year, and we had 10 that were selected to be part of the payment accuracy review. That's 0.3% of everybody that we served. Of the total benefits that were issued and reviewed, we had $2,113 that were looked at, and we had $149 in total errors. So that's an 8% error rate. If you take 149 and you divide it by 2,113, it's actually like 7.05, but they round up, not like standard rounding, but like really round up. So that 8% figure could really result in having $1 million bill to our property tax within Scott County, depending on where we land as a state. I think also of note is that 45% of the errors in 2025 were caused by client errors, and we'll kind of get into, on the next slide here, a little bit more about really what makes up kind of some of the challenging aspects of this. So one is, the error rate does not really reflect how complicated the policy is. So as Matt talked about, we have system workarounds that are routine. And when the policy doesn't align with that, our staff are they're having to override the system, they're having to override the rules. There's a tremendous amount of pressure that's placed on our staff right now, knowing how many millions of dollars are at stake. And when our systems aren't prepared for helping to support that, the pressure is felt on the frontline staff. In addition to that, there is no single source of the truth. So we have two areas really that create the most amount of errors, that is income and deductions. We have 12 different manuals totaling 300 pages just for those two elements. That doesn't even look at our combined manual that they have to reference. So we have antiquated systems that they're having to go through different policies to make sure that they're determining this information correctly. In addition to that, our counties are going to be penalized years after the work has been done. So we are on the clock beginning October 1st of this year for the payment error penalty that we will feel in October 1st of 2027. So October 1st of this year was when the federal government shut down and SNAP was impacted. In addition to that, as the presentation before us just pointed out, we have experienced a series of continuous disruptions that has impacted both the state and the county. And so, again, we're trying to manage this in an area where we don't really have any room for error. Counties are also going to be liable for errors that we didn't commit. So again, back to the previous page, when clients make errors, they forget to inform us if they have a change in their employment, minimum wage goes up, something happens, they just don't report it to us. That's a county error. In addition to that, we just want to point out this error rate, and this is actually stated on CMS website, this isn't fraud. This is really the ability to determine eligibility accurately. And if we see an overpayment within a client error, we go back and we correct that. In addition to that, within this error rate, if we underpay a client, that's also an error. So client errors, underpayment, overpayments that we correct, all of that is included. And again, as Matt outlined, really our systems really aren't set up to handle some of the infrastructure pieces that are needed to determine this equitably for us. And then lastly, just SNAP was really intended, it's a federal entitlement program. And so this is right now being, if nothing changes, this is going to fall on county taxpayers. And I know for us within Scott County, that is going to be some really real hard decisions about what we do with things like family resource centers, things that we have committed resources to that we're seeing promising practices with kids not moving into out-of-home placements. And these are things that are going to be on the chopping block if this gets shifted to the county level.
Thank you, and welcome to the committee. And also, please state your name for the record and begin.
Thank you, Madam Chair. Good morning, members. My name is Garrison McMurtry, and I'm the Ramsey County Commissioner representing District 3 in the county. I'm also here as a member and on behalf of the Association of Minnesota Counties. Today's hearing is very important because the impacts we're discussing are not theoretical. They're real. The policy shifts affecting SNAP and Medicaid are happening. The only question left is who pays. And if those costs are pushed down to counties, they will ultimately be pushed onto property tax owners. A shift, whether it's from the federal government to the state government or the state government to the local government, doesn't eliminate the cost or the bill. It just changes the mailing address. Ramsey County just came off of a near double-digit levy increase after cutting positions and reducing critical program areas that we know have had added value and provide positive upstream impacts in areas of housing supports and youth and families. Next year will be no easier. There is simply no capacity to absorb federal cost shift of this size, and unlike the federal government, counties don't print money. Unfortunately, we levy it. Every county in this state has a different tax base and different economic realities. But I can say this clearly, all 87 counties are unified in warning that this is unsustainable. At the AMC annual conference in December, all counties were speaking to these changes and how it could double or even triple their levy increases into the future. And we know that it will impact some of our most vulnerable communities. In an era when getting counties, 87 counties in particular, to agree on anything is fairly difficult, that should tell you something, that it's beyond politics, it's an actual harsh reality. We are also not silent with our federal partners. We've met with them in Washington and in district. We've written letters to the editors, hosted press conferences and demonstrations. We will continue pushing for changes, but we also need the state's partnership. SNAP is a federal eligibility program, and Minnesota is unique in that we are amongst a dozen or so states in the country where SNAP and Medicaid are administered by the counties. So counties are asking you, our legislative leaders, to put protections in place so that counties like mine don't see historical property tax increases, which we know compromise an individual's ability to afford to stay in their home, especially our elderly and vulnerable populations. Not just homeowners, as Mr. Hilgart mentioned, but renters too, who absorb the cost of property taxes as well. So as our state partner in this effort, there are a couple of things that we're looking for. One, we need clarity in law for who is responsible to pay for the state's error rate penalties. Second, we need counties to be held harmless to any additional administrative cost shifts. And finally, we need IT modernization prioritized now. Not years from now, but now. Because once again, as Mr. Hilgard pointed out, the pressure on our systems and staff is intense, and the policy changes already enacted will exhaust and break the system of all of us. Clients, hospitals, health plans, taxpayers, all of us. In many ways, what we're seeing in confusion, instability, and workload rivals or exceeds what we experienced during COVID. Our staff are working overtime to interpret shifting federal guidance, redo applications, override systems that don't calculate correctly, and answering calls from confused residents. Now, if professionals running these programs are struggling to keep up, imagine the experience of a family suddenly unsure whether they can buy groceries next month, and trying to submit a SNAP elder waiting for medical assistance approval, not knowing whether they can receive their planned medical procedure or get their essential prescriptions filled. These are human consequences. Adding more mandates, more cost shifts, and thousands of pages of new policy onto an already strained system does not strengthen it. We appreciate the seriousness with which this committee is taking these issues. We believe addressing the fallout from this legislation is a nonpartisan responsibility. Protecting residents, protecting taxpayers, and ensuring that counties can actually administer the programs that the state asks us to run. We would also welcome the opportunity for members to see the technology systems counties are working with. I have no doubt that it will be eye-opening to so many of you here. Stability is not partisan. Functioning government is not partisan. And right now, both are at risk. And so with that, I thank you for your time and thank you for your continued partnership.
Thank you. Thank you very much, all of you, for this presentation and really giving us, detailed lay of the land. I did want to mention for members that we will definitely be discussing IT modernization in depth. I have been in discussions, and I know many of us have been in discussions with counties, with DHS, with DCYF, with Minute. This is going to take a collaboration of all of these entities to come up with ways that we can look in the short term to simplify or make strategic investments in IT work that can happen, that can help to mitigate some of the issues that have been brought forward. And so we will definitely have more discussions about that in the weeks to come. And if you have ideas or suggestions, I hope that you'll bring those to us. And are there any burning questions about the presentation? No? All right. Okay, thank you very much. And we will continue now with other public testifiers. And our first testifiers, I have, why don't Lisa Mattson, and if Joe Schindler could also come to the table, and we can welcome to the committee, and please state your name for the record, and you can begin.
Chair Wicklund and members of the committee, my name is Dr. Lisa Mattson, and I have the honor to serve as president of the Minnesota Medical Association, the state's largest professional association for physicians, representing over 10,000 physicians in every corner of our state. Thank you for the opportunity to testify today regarding the federal impacts of H.R. 1 on healthcare in Minnesota. Minnesota's healthcare system is deeply interconnected with federal policy. Changes at the federal level directly affect patient access, physician workforce, and financial sustainability of clinics and hospitals across our state. H.R. 1 contains a number of provisions that will significantly affect how Minnesotans access care and how physicians are able to deliver it. First, Minnesota DHS estimates that H.R. 1, the One Big Beautiful Bill Act, will reduce federal Medicaid support to Minnesota by approximately $1.4 billion per year. These federal cuts will force Minnesota to make difficult decisions about reductions in medical assistance eligibility, coverage, or provider payments. The nonpartisan Congressional Budget Office estimates that up to 140,000 Minnesotans will lose MA coverage over the next 10 years. Federal cuts to Medicaid will render thousands of Minnesotans as being uninsured. Second, H.R. 1 includes major changes to federal student loan policy that will directly impact the physician workforce pipeline. Beginning July 1st of 2026, professional students, including medical students, will be limited to $50,000 annually and $200,000 in lifetime borrowing. The new lifetime cap fails to cover the average cost of medical school, which now exceeds $200,000. More medical students will have to turn to private lenders with less favorable terms. With new caps in place, many students, particularly those from low-income families and rural communities, may find medical schools financially out of reach. Increased debt burden makes it more challenging for graduates to choose primary care, psychiatry, or rural practice, precisely the areas where Minnesotans face the most acute shortages. At a time when our state is working to expand access to care, strengthening rural training pathways, and address behavioral health gaps, these federal changes are pushing us in the opposite direction. Lastly, as you know, H.R. 1 did not extend the enhanced premium tax credits to make coverage more affordable for thousands of Minnesotans purchasing insurance through MNsure. As those enhanced subsidies expire, about 62% of MNsure enrollees, roughly 89,000 Minnesotans, are expected to see financial assistance reduced, and nearly 19,000 may lose assistance entirely. On average, families buying coverage through MNsure are now paying more than $2,100 more per year. Every congressional district in our state has families experiencing these increases. When coverage becomes unaffordable, people do not stop needing medical care. People delay treatment and eventually go to emergency departments. That places additional strain on clinics and hospitals, increases costs across the healthcare system, and most importantly, results in overall worse health outcomes for patients. The combined effect of reducing Medicaid funding, new barriers to medical education, and the loss of premium assistance create a compounding risk. Fewer resources to care for patients today and fewer physicians available to care for them tomorrow. Minnesota has long been a national leader in healthcare quality and innovation, but we cannot maintain that standard without a stable federal partnership and a sustainable workforce pipeline. On behalf of the Minnesota Medical Association, I urge lawmakers to carefully consider the downstream impacts of these federal changes and to explore state-level strategies to protect patient access, preserve the physician workforce, and maintain the strength of Minnesota's high-quality healthcare system. Thank you for the opportunity to testify. I'm happy to answer any questions you may have.
Thank you very much. And I neglected to state for the testifiers that we have given people a 5-minute limit, and if you have less than that, that's fine. But if you could please keep your testimony to 5 minutes or less. Welcome to the committee. Mr. Schindler, please state your name for the record and begin.
Chair Wicklund and committee, my name is Joe Schindler, and I'm the Vice President of Finance Policy at the Minnesota Hospital Association. You'll be happy to hear I chopped out a bunch of my stuff, so I should be less than 5 minutes. All of you know the financial hardships hospitals are facing these days, both large urban hospitals, well documented, and small rural hospitals across the state. I will point out the latest community benefit data that we collected documented a 40% increase in charity care costs, 40% increase to $342 million, and that was in 2024. That'll be an important number going forward here. Now I want to discuss what elements of H.R. 1 are going to impact healthcare across the state. In terms of the Medicaid piece of it, the state-directed payment cuts that are coming, and then the Rural Health Transformation Program. There are 3 major challenges the state will see go into effect January 1st of 2027. And you all know these in the Medicaid world. There will be Medicaid redeterminations will be required twice a year versus once a year. Medicaid work reporting requirements for 80 hours a month. And then Medicaid retroactive coverage moves from 90 days to 30 days for the Medicaid expansion population and 60 days for all others, which could have a major effect of, again, coverage for some of those emergency room visits. Unfortunately, we've heard about the antiquated IT systems currently operated in the Medicaid system. We've been in close contact with the Association of Counties and trying to help support their efforts to get the state systems updated. And as we heard earlier, it has to happen now. Otherwise, some of these losses of coverage, estimated at 140,000 people losing coverage, could be much higher, which has a downstream impact. And I will remind you the real cost of Medicaid coverage drops falls largely, first and foremost, on patients, real people. But in the only place they have to go is the emergency room for the most part. So the costs will be borne largely by hospitals and health systems throughout the state. We are conservatively estimating with these coverage drops that we would see increased charity care of $269 million for those that are currently on Medicaid that now become uninsured. And my doctor colleague next to me also pointed out a very good point, which is happening right now as of today with the ACA enhanced premium tax credits that did not get funded by Congress. We are also seeing people drop coverage or drop to lower level coverage with higher deductibles that are largely what we have found unaffordable when you actually have to get hospitalized. And so we're estimating those costs to be around $115 million. So if you take the $269 million plus the $115 million in additional uncompensated care to hospitals, that's $384 million compared to the $342 million in charity care costs for 2024. Next, I'll turn to the state-directed payment program. This is a program that actually was passed in this legislature last year to help support hospitals and get better sustainability of the Medicaid program. But given the rise in federal spending for these programs, H.R. 1 puts limits on the hospital assessment side of the equation and also additional limits on the hospital reimbursement side. As you recall, last year, it was signed into law in May, and the Department of Human Services did a good job of getting the preprint or application sent into CMS prior to the signing of H.R. 1, so July 3rd, it was sent into CMS, and then July 4th, the H.R. 1 bill was signed. Despite that, CMS has come out with some guidance that seems to indicate that we may not even get our directed payment program. CMS has interpreted H.R. 1 to be in a much stricter way, and it may limit our ability to even capture those dollars, let alone have a program altogether. Now, we did get some recent information from CMS that may be opening that crack, but we think it'll be months before this will be resolved. The program was already supposed to be started this year and is on hold as we speak. So we are in limbo on the state-directed payment program. Now, turning to the Rural Health Transformation Program, the $50 billion fund over 5 years, we are cautiously optimistic that this program can provide some level of funding relief, funding to modernize and transform some of the operations of our rural hospitals. And we were pleasantly surprised that the state was able to get first-year funding of $193 million, which is under review at CMS right now with their revised budget. We hope to hear by the end of next week, I think, from CMS whether that will be approved. The federal RHTP objectives are very focused on building care management for chronic conditions, workforce development, supporting partnerships, a heavy emphasis on technology-enabled improvements for such things as telehealth, cybersecurity, and revenue cycle improvement. But I want to be clear, the funding is specifically not allowed to support uncompensated care or other service line shortfalls, which is what the rest of H.R. 1 is causing to happen in this program. Furthermore, this funding is roughly equivalent to the charity care costs that we already have in the state. So we again, could more than double our charity care costs for hospitals across the state. The Minnesota Department of Health has taken the lead role from the state to administer the program, and they have clearly stated that 70% of the funding will be allocated to hospitals as they are the healthcare safety nets for their communities, especially when Minnesotans lose their medical insurance coverage or wrestle with high deductible health insurance that becomes unaffordable for many. While RHTP appears to be helpful, it's targeted to benefit only 94 hospitals. These are rural hospitals, which leaves another 30 or so urban hospitals and community hospitals that have no positive financial impact from H.R. 1. So we are working with Minnesota Department to better understand the RHTP implementation strategy. We know that there's going to be a few complications. Because it's a restricted grant, the CMS is going to have to be fairly heavily involved in approving all of the grants that are pulled out of this, that are granted through the system. We also know that CMS is currently reviewing the state's revised budget. And then lastly, the MDH has stated they're implementing the program as a reimbursable grant program. So the program it says that you will only get paid after you have incurred costs, which puts hospital providers in a financially precarious situation. We realize this is a safety measure to ensure greater anti-fraud protections, but it may be prohibited for some financially stressed hospitals to even participate. So again, we welcome the Rural Health Transformation Program funding to support rural hospitals and healthcare access, but we have some concerns about the administrative costs, along with upfront spending expected from rural hospitals to participate in the program. In conclusion, you can see the most severe impacts of H.R. 1 will impact Medicaid enrollees who will lose Medicaid coverage. These are the poorest of the poor, and largely through no fault of their own will be uninsured. While we recognize there may be some levels of fraudulent waste that may get wrung out of the system, the vast majority of these impacts will be borne by those who legitimately need the coverage. And as for financial impact, as I've outlined, a significant financial burden of these cuts will fall directly on hospitals across the state in the form of charity care. So with that, I'll stop.
Thank you. Thank you very much. And members, there are a couple handouts in your packet that have some of these impacts laid out by the Hospital Association.
Yeah.
Thank you very much to both of you. Now I'd like to call up two more testifiers, Colton Stedman and Jose Alveolar, and I apologize if I mispronounce your last name. And testifiers, when you finish, you can certainly leave the table, go back to your seat. Welcome to the committee, Mr. Stedman. If you please state your name for the record and begin.
Good morning. My name is Colton Stedman. I would like to thank the members of the committee for holding this hearing and for providing the opportunity for me to speak to the impacts of H.R. 1 and the expiration of the enhanced premium tax credits. I have been a licensed insurance agent in the state of Minnesota since 2013 and a MNsure certified broker since 2015. During that time, I've helped hundreds of consumers compare their health insurance options available in the Minnesota market and hopefully select the best plan for their family. According to the 2024 report from the census, health insurance coverage in the United States, 10.1% of the population purchase private coverage directly from an insurer. I'll refer to this as the individual market. I often describe the individual market as the option of last resort. As most of you are aware, the United States healthcare system is built around employer-based private payer model, with the majority of Americans, 53.8%, getting their health insurance from their employer. The individuals seeking coverage on the individual market are small business owners, independent contractors, employees of firms who do not offer group health coverage, disabled individuals waiting 24 months for Medicare eligibility, retirees, individuals working multiple jobs, part-time jobs that do not offer or they are not eligible for benefits. These are my clients. These are the people I work with every day. To describe this past open enrollment period as challenging would be an understatement. The expiration of the enhanced premium tax credits, paired with an average base rate increase in Minnesota of 20%, resulted in huge increases to consumers' renewal premiums. There are plenty of stories in the media about these impacts, but I'll share two from my clients here today. A 64-year-old couple retired in Rochester. Their costs in 2025 were $73.09 per month, or $877.08 per year, for a copay plan with a $13,600 out-of-pocket maximum. That's the worst case scenario, what you pay in a calendar year for medical expenses. In 2026, their premiums are $2,865.08 a month, or $34,380.96 for a high deductible plan with a $17,000 out-of-pocket maximum. This is an extreme example where a household of two exceeds the $84,600 cutoff, or cliff, I refer to it as, and no longer qualifies for any tax credits. They certainly didn't anticipate that deciding to take their Social Security would cost them tens of thousands of dollars a year. Just for reference, their household income in 2025 was approximately $42,000, and in 2026 is $87,000. My second example is a 62-year-old widow in Roseville. In 2025, their cost was $145.68 a month, or $1,748 per year, for a copay plan with a $9,200 out-of-pocket maximum. In 2026, their cost is nearly doubling, more than doubling, to $362.97 per month, or $4,355 per year for a copay plan with a $10,600 out-of-pocket maximum. They qualify for tax credits, but the combination of base rate increases and tax credit changes resulted in more than a doubling of their costs. This past fall, I spent hundreds of hours having the same conversation with my clients over and over. Many were in tears, many were angry. Certainly some of them said, "I just can't afford that." Clients decided to reduce coverage, change to a plan that didn't cover their doctors that they'd seen for years, or just go without. The grace period for binder premiums on February 1st coverage is fast approaching, and I am curious to see how many consumers decide to roll dice and go without coverage in 2026. Thank you.
Thank you. Excuse me. Thank you. Thank you for your work, and thank you for your testimony today. Please state your name for the record and begin your testimony.
Good morning, Madam Chair and members of the committee. My name is Jose Luis Hinojosa, and I am a lead organizer at Unidos Minnesota. I am also the son of two hardworking parents who have lived most of their lives here in Minnesota, a place they have called home, and just as any other resident of the state, they pay their fair share and file their taxes. Yet all of their hard work has amounted to nothing in the eyes of others who would choose division and hate over simply caring for all Minnesotans. I'm here today not just as an individual, but as the child of hardworking Minnesotans whose lives and the lives of countless others have been profoundly affected by the ripple effects of healthcare policy changes, including those stemming from the funding reductions in H.R. 1. We were already struggling with inadequate state funding for vulnerable communities. Now the loss of access to basic health care is being intensified by a climate of fear. In our communities, the presence of federal immigration enforcement has become a stark barrier to care. We are living in a moment where families, regardless of immigration status, are not only unable to access health care, but the health care that they need, but they quite literally fear for their own safety so much that they will avoid seeking medical attention entirely, even in emergencies. I know this fear intimately. My own mother, who should be enjoying the peace of mind that her years of hard work have earned, was forced to make impossible choices. Because of the extremely high prices of medication, I watched her ration her necessary prescriptions, cutting pills in half and stretching a 30-day supply into 45 just to make ends meet. That is the devastating human cost of a broken system and inadequate funding. The effects of massive congressional cuts will be felt for years to come, for families like mine. With the loss of medical assistance, regular working people will be pushed off of health insurance, creating a devastating void. If health is wealth, this is not how we bring prosperity to our state. Vulnerable communities in greater Minnesota, and people with accessibility needs are at risk of suffering preventable deaths as care declines. I urge you to work with your colleagues to pave the way for added funding for our healthcare infrastructure and to restore healthcare access to every Minnesotan. Thank you.
Thank you very much for your testimony. Now I'd like to call up Sophie Wallerstedt and Karen Spitzfaden, and also Sophia Lenars-Coy. Welcome to the committee, and Ms. Wallerstedt, did you wish to go first?
Yes, let me plug in my laptop to put up the slides. Thank you.
We'll see if it magically appears or if we need.
There's like a secret code.
There we go. Looked like we were close.
We were there. You're going to pull it up? Okay, thank you.
And
Yeah, I can go. So,
go
thanks,
ahead,
Chair
yeah.
Wickland and
Please
members
state
of,
your name for the record and begin.
Thank you, Chair Wickland, members of the committee. My name is Sophie Wallerstedt. I'm the Public Affairs Manager at Second Harvest Heartland. We are a food bank in Minnesota that is actually now the second largest food bank in the country. We got that recognition late last year. We serve 41 counties in Minnesota. And I'm going to pass it over to my colleague Karen Spitzfaden, who will be talking a little bit more about the hunger and food insecurity survey that we started 2 years ago and have some updated numbers for you.
Thank you. Welcome to the committee, and if you can state your name for the record.
Yes, thank you, Chair Wickland and members of the committee. My name is Karen Spitzfaden, and I'm the Director of Consumer Insights at Second Harvest Heartland. And as Sophie said, I'm here to just give you an update on the number of Minnesotans that are experiencing hunger and food insecurity. So for the second year, we partnered with Weiler Research to better understand whether Minnesotans have enough food and also how many of them are relying on food shelves, SNAP, and other food assistance programs. In 2025, so that's our latest study, we learned that 1 in 5 Minnesota households cannot afford the food that they need. So we also know that the Hunger Relief Network is doing a pretty remarkable job of ensuring that most of those families still have the food that they need. But we know that there are, in fact, more food insecure households than there were a year ago in 2024. And we also know that the numbers are on the screen now. So we're looking at about 22% of Minnesota households in 2025 are food insecure. They can't afford the food they need. That's compared to only 20% in 2024. So like I said, there are more families in 2025 that are food insecure. And we also know that 42% of Minnesota households are concerned about their sort of household stability. Food is really expensive, and as families face rising costs for nearly everything else in their lives, they need help getting enough food. You have a lot more information about the methodology and details of our study in your packets, but I do want to note that we conducted the study in August of 2025, so it actually doesn't reflect the impacts of HR 1, and my colleague Sophie's going to talk a little bit more about what we expect from that. Thank you.
Thank you, and go ahead and state your name for the record again.
Great. Again, I'm Sophie Wallerstedt with Second Harvest Heartland. I know you have already heard a lot from the state and the counties about the impact of HR 1 on Minnesotans, but I just wanted to reiterate a couple of things. Essentially, these 3 changes in particular are going to have very significant impacts both on the state and taxpayers, but also Minnesotans who rely on nutrition assistance to keep their families fed. So the first piece on the state cost share, I won't spend too much time on this since you've already heard about it, but I do want to underscore the impact that this will have on the state, counties, and community organizations that help individuals apply for SNAP. The second piece is on those eligibility changes. This will include a significant increase in work reporting requirements for almost 28,000 individuals in Minnesota. This will add an additional administrative burden to county workers and additional hoops for recipients to jump through. Additionally, and this is on the slide, but over 9,000 legal non-citizens with humanitarian status are now ineligible for federally funded SNAP. I do want to note that this includes families from Ukraine, people from Afghanistan who supported our troops while we were over there, and survivors of human and labor trafficking who worked with federal authorities to prosecute their exploiters. And then the last piece I want to highlight is a little wonky, and I won't get into too many details, but excuse me, HR 1 also limited the USDA's authority to adjust the Thrifty Food Plan, which is a formula that is used to estimate the cost of groceries and then determines the benefits that families receive. When we don't allow those benefits to increase, it makes it harder and harder for families to afford the food that supports a healthy diet. So I will say that all of these changes will directly impact the hunger relief system in Minnesota. We know that for every meal that the food shelf and food bank system provide, SNAP provides 9. So for even a 10% reduction in SNAP support, that would result in us needing to essentially double our entire emergency hunger relief system to fill that gap. We know that that is impossible. And then I'll just pass it over to Sophia to speak more on the impacts that food shelves are seeing now.
Welcome to the committee, and please state your name for the record and begin.
Thank you, Chair Wickland, members of the committee. I'm Sophia Lenars-Coy. I am with the Food Group. We are another nonprofit in the hunger relief space. We work statewide and work across the food system. So I just wanted to share a little bit, as my colleagues have shared, about how this impacts the food shelf system. And we can go to the next slide, Sophie. Thank you so much. Again, this year, we saw over 9 million visits to food shelves in the state of Minnesota. When you compare that to 2019, before the pandemic, this is about 2.5 times more visits. There are food shelves in every county of Minnesota, and these trends are showing in rural communities, urban communities, and suburban communities. We continue to see over 9 million visits, and I think this is starting to be the new normal, and likely probably is an indication that the food shelf sector is at capacity, right? So one thing we saw in 2020 when we saw the big jump from the 3 million visits up to 9 million is we did see an influx of federal funding support and state support that allowed the system to really increase in size and scope. But as Sophie from Second Harvest mentioned, for every meal provided, SNAP provides 9. So when the system is already at capacity, we're very, very concerned as we look ahead to the impacts of the changes to SNAP. So again, with the SNAP cuts and the additional work reporting requirements, what we see is food shelves are often the first line of defense. So that pressure is going to increase. We saw that, even briefly when SNAP funding was frozen in November, people go to the food shelf, they ask for additional food. They also ask for clarity around the SNAP program from volunteers at the food shelf as well. Food shelves are not designed to replace SNAP. They really are designed to supplement it. And given the pressure already on the food shelf system, we just are all concerned, again, at how we can continue to have that statewide safety net program. So we can go to the next slide. The other thing I wanted to just, first of all, thank all of you for is that Minnesota does have the Minnesota Food Shelf Program to support food shelves, thanks to many of your leadership and support. It has been around for over 30 years, a long track record of really good site visits, compliance, solid community relationships, high community trust. There has been an ability for the state to put one-time money into the Minnesota Food Shelf Program for the past couple years. That has been incredibly beneficial, and we will be asking for continued investment in that program, again, to buffer what is coming. I know this committee has heard a lot of really overwhelming statistics and budget gaps this whole testifiers, but I think that the Minnesota Food Shelf Program is a way to take very limited resources and make sure they get to every county in the state and do some good in these really challenging times.
Thank you all very much for your testimony. I appreciate it.
Thank you. One quick second.
We're going to move to one of our Zoom testifiers. Is it? Oh, not Zoom. I'm sorry. We have a testifier who is Munira still here? If you would like to come forward and provide your testimony. Looks like, well, she went to the hall, so I don't know. We'll see if she comes back. Why don't I call forward Nick Kelly, if you could come forward, Director of Public Health, and then Robin Williams. And there's, and Munira, if you'd like, oh, she's gone, okay. Welcome to the committee, and please state your name for the record. And we are going to run close on time, so if there's a way that you can make sure you keep to 5 minutes, I would appreciate it. Thank you.
Thank you, Chair Wickland and members. My name is Nick Kelly. I'm the Director of Public Health for the City of Bloomington. Our health department serves Bloomington, Richfield, and Edina. And I'm also speaking on behalf of the local Public Health Association of Minnesota for portions of this testimony. Minnesota is very proud of our public health system. It is recognized across the country as leaders and innovators. We need to modernize that system, and the lack of consistent federal support threatens that. A recent joint leadership team has come up with a vision for what that future looks like. It's a seamless, responsive, publicly supported governmental public health system that works closely with the community to ensure safe, health, and vibrant communities. This work requires a sustained investment in public health. In 2023, the Minnesota legislature made a significant investment in local public health. Thank you so much for doing that. That investment has been transformative in our ability to do public health. However, we see reductions in federal support for public health threatening the system, creating systems of inequities across the state that threaten our ability to do our mandated duties. Across local public health agencies, federal funding has historically been the backbone of our work, often a third of our budgets, supporting programs like WIC, home visiting, and immunizations. In our team, I have 14 FTEs that are supported by federal funding. In 2025, that staff in WIC served 3,082 individuals. Our home visiting team served 306 individuals. We provided 410 immunizations for individuals without insurance. And our ability to prepare and respond to public health emergencies for the 180,000 people that call our community home is dependent upon federal funding. That stability changed in 2025. Federal funding dropped by $400,000 for our department, while state funding increased by $700,000. For the first time, state funding usurped the federal funding, and that trend has continued into 26. We recently just navigated the longest shutdown in history. In response, Bloomington City Council allocated $250,000 to meet emergency food needs in our community to 4 partners, providing over 10,000 households support in November and December. That continues today. In January, they moved forward $350,000 for housing support. Both of these are emergency stopgap measures that are not sustainable to meet needs. Now we face additional threats. Last week, we learned of 5 CDC-funded programs, including the Public Health Infrastructure Grant, that are being canceled. In Minnesota, about 200 local public health staff are supported by the FIG grant. 5 of them are in Bloomington. In Northwest Minnesota, this provides health educators working on mental health and suicide prevention. In Central Minnesota, this funding supports staff doing mandated community health work and building gaps or addressing gaps in dental health access. It staffs 12 folks in Minneapolis, including the mobile medical unit. This funding was designed and built out to strengthen our public health infrastructure with stability for 5 years. Losing it means losing ground every year, forcing local taxpayers to absorb costs and accept reduced service. Work under this grant is continuing, as you heard, due to a temporary restraining order that paused the termination. Minnesota already has some of the most profound health disparities in the country. When one part of our system falters, the entire system suffers. The recent community health assessment we do in partnership with Hennepin County, the City of Minneapolis, and Edina and Richfield identified mental health and access to basic needs as the greatest health issues facing our community. In my role in Bloomington, I've seen that challenged tremendously in the last few months with recent federal immigration action. We've seen disrupted access to preventative care like prenatal services and vaccinations. Fear and instability are impacting mental health and trust in government. Trust that's going to take significant resources to rebuild. If federal investments continue to decline, tribal, state, and local governments cannot fill that void. Our ability to provide seamless, responsive public health systems depend upon sustained support, modern tools, and shared leadership. Without that, we risk losing the foundation that keeps our community healthy, safe, and resilient. Thank you.
Thank you very much for your testimony. I would just want to ask, are you Munira?
Yes.
Okay. And you had a time constraint?
I I did, yes.
Yeah, if you could please state your name for the record and provide your testimony, I'd appreciate it.
Yeah, thank you so much. My name is Munira Malam-Isaac. I'm a family nurse practitioner and the CEO of Inspire Change Clinic. I am here today to share stories about, of community members who were impacted by Metro surge, ICE. That was the last couple
And
of
if you
months.
could please speak really closely to the microphone, please. Thank you.
Yes, definitely. Since December 2nd, we've noticed that patients were calling and canceling their appointments. 50 to 60% of our patients were not showing up in the clinic. And because of that, we wanted to understand why and figured out what the barrier of patients coming into the clinic was. We ended up finding out it was because of fear of ICE and not wanting to come in or leave their home. We gathered and figured out a way that we could provide care to patients in their home. We have 153 doctors, from cardiologists, primary care, neurologists, who have signed up and said, how do we provide care to patients that are not leaving their home? We received a phone call from a mother, I can remember, on earlier on, and she said, I think I'm in labor. It was myself, and I called one of our volunteers who's an OB and asked if she could go with me. By the time we got to her home to just check her, she checked her cervix and she was 8 centimeters dilated, but refused for us to call 911 to get an ambulance for her to be taken to the hospital. We ended up giving her a ride to the hospital ourselves in my small Tesla, hoping that she would not have a baby in the back, but got her to the hospital safely. And that's not the only story. I've seen grandmothers who are taking care of their grandbabies who are U.S. citizens, grandmothers who have lived here for 30 years, pulling out their hair where the skull is actually showing and have wound care that needs to be done. I have seen people that did not pick up their seizure medications and now just inability to pick it up and needing someone to deliver that to them. I've seen moms who were too afraid to go grocery shopping for their young kids, and when we went there to do sutures for a child who cut themselves, I asked, hey, I knew a house that has home and a house that doesn't. I'm a mother of 3 myself, and the older daughter said, no, we are good, we have food. This is the 11-year-old. But the 4-year-old goes, no, we don't have any food, we need food. And he says it in Spanish. I don't speak Spanish, but the other person that volunteered spoke Spanish. And we were able to get them food and provide that dinner to them. Otherwise, they would have gone hungry. Moral of the story is what is happening to our communities is truly sickening and inhumane. The system is failing them, and we want to make sure that we're providing care to people. Once, I'm not doing this work as someone who's leading Inspire Change because it's for the people, but I am the people. I am the people that are being impacted by what has happened. I carry my passport around, not because of something that is new, but just something that has to be done just to make sure that I can go home to my kids and provide care to my patients. Before, having a volunteer who was Caucasian, I personally thought that was a safety net for me, but I'm finding out that it's not even a safety net anymore. And thank you so much for listening to my stories, and I hope we all can see that access to healthcare is one of the most fundamental things that we can provide to people while they figure out their citizenship or their immigration status. Thank you.
Thank you. Thank you very much, and thank you for being able to stay. So, but feel free to go now if you need to. And Ms. Williams, if you could please state your name for the record and begin.
Yes, hi, I'm Dr. Robin Williams, and thank you to this committee and Madam Chairwoman for the opportunity to speak. I'm actually going to be talking today about the impacts of the current funding situation on pediatric cancer research, and honestly how it's having an effect on children across the country, including those living in Minnesota. To give you some context, I'm an assistant professor at the University of Minnesota in the Department of Pediatrics within the Division of Pediatric Hematology and Oncology. And in this role, I wear many hats. One of those is I'm a physician who treats children and young adults with blood cancers. I'm also a translational laboratory scientist investigating ways to engineer immune cells to fight cancer and developing new, novel, targeted, less toxic treatments for patients with blood cancer. And I'm also a clinical researcher serving as the University of Minnesota's principal investigator for the Children's Oncology Group, which, if you're not familiar, is the world's largest clinical trials consortium devoted exclusively to childhood cancer research. In the United States, 15,000 children will be diagnosed with cancer each year. And luckily, thankfully, due to the strong past support from government-funded research projects, most pediatric patients will survive their disease. This group of diseases ascended from an incurable rate 50 years ago to now nearly 85% of patients today will survive their disease. But that was because of the That was because for decades, our nation collectively chose to prioritize medical research and innovation for these patients. In the last year, though, federal funding through the National Institute of Health, including funding for pediatric cancer research, has plummeted to a historic low, in which now less than 4% of grants are being funded. For perspective, prior to the recent funding cuts, 10 to 15% of grants received funding. And just to give you an example, I am currently on a recent grant submission as an investigator in which the score that we received would have easily fallen within the pay line previously. And the reviewers stated in their review of our grant, quote, "The outcomes of this work has the potential to inform immune leukemia, cell biology, and lead to the development of novel therapies. The application clearly laid out the benefits and challenges were well addressed. Overall, the weaknesses were mitigated by the numerous strengths, and the panel agreed this application was of high impact," end quote. Sadly, this vital cancer research remains unfunded, and this delivers another devastating blow to pediatric cancer patients relying on this basic and translational research to find more targeted and less toxic therapies. And although I've already touted the fact that collectively most pediatric patients will survive their disease, there are certain cancers that remain incurable or rarely curable, such as many subtypes of brain tumors, and the depth of these current cuts means these diseases will remain terminal diagnoses. Then there's the clinical cancer research for pediatric patients, which is being stretched thin under the current budget. The Children's Oncology Group, which I mentioned earlier, does continue to receive federal funding, but that is not the case for all the federally funded clinical pediatric research initiatives. One notable example was the abrupt termination of all federal funding for the Pediatric Brain Tumor Consortium. This was a 26-year federally funded collaborative network that conducted groundbreaking research for early-phase clinical trials of novel treatments for primary brain tumors in children. To preserve as many active trials as possible and prevent the loss of trials in development, a subcommittee within the Children's Oncology Group did absorb those trials. However, it did so without additional funding. And despite their best efforts, some of the pediatric brain tumor consortium trials will close prematurely. And researchers and physicians like myself in those who are treating pediatric brain tumors are warning this shift could reduce the focus on this very specialized, life-saving pediatric brain tumor trials. As I have already noted, within this group, there's a large number of disease subtypes that remain incurable or rarely curable. I could clearly speak for hours about the concerns I have for the future of pediatric cancer research and the implications it has on the health and well-being of children living with cancer. But I clearly understand there's many things to be spoken about today. But I do appreciate even the few minutes that I've gotten to discuss this with this committee. And I thank you on behalf of the scientists and the young patients that I treat.
Thank you. Thank you very much for your time. It's really troubling to hear about the losses that we could face. Next, we will go to, we have two testifiers on Zoom. First, I'd like to call Dawn Uribe. I hope I'm saying your last name correctly. Apologize if I'm not. And Dawn, if you could come off mute, and then please state your name for the record and begin your testimony.
Madam Chair and members of the committee, my name is Dawn Uribe. I am the CEO and owner of Mis Amigos Spanish Immersion Preschool. We serve infants through pre-K. We operate like any other licensed childcare provider, except we do it 100% in Spanish. We serve primarily English-speaking families who choose our program because they want their children to learn another language early in life. As we all learned over the last several years, childcare is an essential part of the economy. Parents rely on us every single day so that they can go to work and support their families. Since December, we have been facing a new level of uncertainty that threatens our ability to operate. Navigating my business over the last couple months feels like the early days of the pandemic when none of us knew what would happen from one day to the next. I want to share what the recent CCAP funding confusion and the surge in federal immigration enforcement has meant for our families, our children, and our mostly immigrant staff. Since January, we've received anxious calls from parents asking what will happen if CCAP funding is frozen. The honest answer is we don't know. We tell them we will work with them so that their child can stay in school. We say that because we care about children and families, but it's not a sustainable business model. Childcare operates on very small margins. Payroll, rent, food, licensing requirements do not pause when funding becomes uncertain. I choose to enroll children receiving subsidies because I believe it's the right thing to do. All children deserve high quality, stable, safe, loving care, but it comes with significant administrative burden and financial risk. With private pay families, tuition is paid before services are provided. With CCAP, we provide care first, and then we bill, then we wait, sometimes months, to be reimbursed. I have approximately 40 children receiving CCAP and scholarships, and a full-time employee whose primary job is managing that billing. If there are mistakes, even small ones, the county can reject the payment, and there's no meaningful appeal process. We simply might not get paid. So when funding becomes uncertain, providers are asked to absorb major financial risk for services that we've already delivered. Many child care centers will not survive a lapse in funding, and when child care centers close, it affects all families. Capacity shrinks, choice disappears, and costs rise. At the same time, we're navigating a second form of instability, the surge in federal immigration enforcement. Since December, I had been hearing stories from my staff about friends or family members being detained, even people with valid work permits. I was skeptical. I thought there must be more to the story. I assumed there must be some kind of criminal history or some missing detail. But then it happened to someone I know. While purchasing supplies for a building project at our school, our maintenance manager was detained in a Home Depot parking lot. He was transferred to Texas and held for approximately 2 weeks. He has been living and working in Minnesota with his family for years. He had legal authorization to work, stable employment, no criminal history, and a pending immigration case. The timing was hard to ignore. That same month, he was being recognized as our Employee of the Month, a recognition that had been planned well before any of this happened. Operationally, this created immediate strain. Child care centers are highly regulated, and we depend on consistent maintenance support to remain safe and compliant. But during those 2 weeks, we were not only running a licensed child care business, we were also supporting a staff community that was shaken. His spouse, who is a preschool teacher at our school for 4 years, and their teenage daughter were navigating tremendous uncertainty. Staff were shaken, families were shaken, children noticed his absence. We all experienced loss and uncertainty. It wasn't that he was gone, just that he was gone. It was the realization that anyone could suddenly be gone. And while we were supporting his family, we also found ourselves coordinating a huge outpouring of community support. Families and community members stepped up to help staff with groceries, fill gas tanks, and meet their basic needs so people could safely come to work and keep their lives stable. It was a level of crisis management I never expected to be part of operating a preschool. And yet our responsibility as caregivers is to remain steady for children. Our staff bravely continued to come to work, even when afraid, to care for our youngest Minnesotans. We kept classrooms open, we kept routines consistent, we protected children from adult details, and we kept the school as joyful as usual. Federal actions, even when they occur outside school walls, ripple directly into our classroom and into the lives of very young children. When funding becomes uncertain and when members of our workforce are suddenly removed, child care providers have to pick up the pieces. We absorb the fear, we absorb the financial risk, we absorb the disruption, and still provide a calm, loving environment for young children. Child care is an essential part of our economy. Parents rely on us so that they can work. Children rely on us for stability during the most formative years of their lives. But stability for children requires stability in the systems that support them. Providers can manage short-term challenges, but we cannot build sustainable child care systems on uncertainty. If we want all families to have access and real choice, funding and workforce systems must be predictable. Thank you for the opportunity to share my testimony.
Thank you very much for your testimony today. I really appreciate it. And now I have Cindy Cunningham. And Cindy, if you can unmute and turn on your video.
Thank you to your aides for doing that for me. I am Cindy Cunningham, a licensed family child care provider in St. Paul for almost 30 years. I'm also privileged to be the public policy chair for Lead and Care, which is the 501c3 statewide association for licensed family child care. You will hear the child noise in the back, and I will turn off my screen so no one's privacy goes. The federal actions over the past months have been stressful for many in our state. For some, it's been beyond stress to the length of life-threatening. Licensed family child care has been a quiet victim in these federal actions. The fraud accusations hit hard. Providers question everything they have ever done in all areas of government-funded programs. The communication was confusing if site visits were being done just for CCAP to centers or to family child care, or for all funding such as early learner scholarships and Great Start compensation. Everyone at the state level was under great pressure doing the best that they could. We really needed better. We needed clearer directions. Our programs were monitored by the counties, and we have relationships with our county licensors. During this process, licensors were left out of the efforts, and state licensing in DCA was to be coming to our businesses and homes. We needed the licensors involved. We were told inspectors in BCA would have badges and identify themselves that they knew how to do their job. However, how would we know it was state inspectors in BCA? Imitators are always possible. The overlap in the Metro surge by ICE Homeland Security added an additional layer. The minority-led programs were rightfully fearful of the presence of ICE. Some experienced ICE hanging outside their programs. What about that child or family in care who was brown or black-skinned? What do they do if someone enters their home or business? Do we have to let them in, or can we stop them at the door? Who needs a warrant? How do we keep everyone safe, including ourselves? We needed more directions from the state regarding steps we could take to protect ourselves and those in care. Some programs closed as the fear overtook them, even those who are legally in the United States. Some parents stopped bringing their children for fear of being snatched and taken away. Many stayed home. There are financial hardships and trauma. What can be done for the recovery? Family child care is uniquely vulnerable as our phone numbers and home addresses are on the licensing lookup. These were made very public from December on. There are no directors or business owners answering the phone or the door. It is a license holder, their private home, and family members being directly impacted. At the same time, simultaneously providing direct care for children. These are 24/7 residents, not standalone businesses. Nefarious individuals were able to call, threaten, and accuse. Some had people outside their homes or ICE walking around waiting for families to show up. What do we do about harassment, phone calls, and threats against lives? Yes, that was happening. The words were hateful and the threats to life scary. We needed direction and support. We had no support from DCF about how to handle these interactions. We were on our own. As a public policy person, I received phone calls, triaged situations, made referrals to resources, and sent communication to programs, attempting to ensure compliance and also knowing what our rights were. We needed more support from DCYF for our businesses. We could manage to have We are individual license holders, typically in our private homes, tucked into the communities. These are unique experience for FCCs. These are our private homes where we live with our families. We are those 24/7 present in our homes, and there's no walking away from the business. We need privacy changes. We can manage to have a second phone number for our business to screen incoming calls. Since the addresses are being specific to our homes, there were programs which were harassed. We cannot change their addresses. We could change our phone numbers. We are asking for a modification to the licensing lookup for the public record. This could be a zip code, a partial address, or some other identifying location without a specific target on our backs. Parents need to find care and know where they are driving their children to. We need privacy. The balance might be difficult. We need to work together to find the balance. Everyone has a story of their experience, survival, or trauma from the federal actions. We all need to work together to ensure that moving forward, we can all do better and that there is a recovery process. Thank you for taking the time to discuss this impact and recognizing family child care in the experience.
Thank you very much, Cindy. I really appreciate it. Members, there are 5 more testifiers, and I would appreciate it if we can go a little over to make sure we can hear from people today. I'd like to call up Marcus Schmidt, Kate Rickard, and I'm not sure if I'm going to say this correctly, Haben Johannes. If you could please come to the table. And if there's anything that you can do to keep your testimony less than 5 minutes, that would really be appreciated. Thank you. And Marcus, Mr. Schmidt, if you please state your name for the record.
Marcus Schmidt, Executive Director, NAMI, Minnesota. Madam Chair, members of the committee, appreciate the opportunity to connect with you all today, although I regret the circumstances. With limited time, it's difficult to fully capture what Minnesotans living with mental illnesses have experienced over the last 6 months. Wave after wave of frightening developments have created sustained uncertainty, anxiety, and fear across our state. Simply put, people are struggling. NAMI Minnesota's helpline data and direct community outreach show clear patterns of destabilization. Individuals living with serious mental illnesses, including schizophrenia, bipolar disorder, and severe depression, are experiencing decompensation, worsening symptoms, and acute crises triggered by prolonged stress. We're hearing from families whose loved ones have stopped medication, disengaged from treatment, or isolated due to fear. We're seeing increased calls related to suicide attempts and suicidal ideation. These are not abstract policy discussions. These are immediate, life-threatening situations. While all Minnesotans have felt fear and uncertainty, people with serious mental illnesses are experiencing disproportionate harm. Constant exposure to violence, tragedy, enforcement actions, and public instability can be destabilizing, particularly for individuals already managing paranoia, trauma, or severe anxiety. For many, this stress is not temporary. It's triggering relapse and crisis. Operation Metro Surge has intensified fear in many communities and across our state. The tragic loss of Melissa and Mark Hortman and the events at Annunciation School further undermine our collective sense of safety. At the same time, many Minnesotans fear losing Medicaid coverage due to federal policy changes and administrative burdens. We support program integrity and fraud prevention. However, corrections cannot come at the expense of people who rely on Medicaid for life-saving mental health care. Loss or interruption of Medicaid mental health services can mean the difference between stability and hospitalization, or worse. At NAMI Minnesota, we have long said the mental health system isn't broken. It's just never been fully built. Even before the tragedies and federal actions of recent months, Minnesota did not have the comprehensive mental health system our residents deserve. The current moment has exposed those gaps even more clearly. We know the solutions. We simply need sustained investment. Mobile crisis response teams and protected transport, a robust statewide crisis response system, intensive community services for kids and adults boarding in emergency rooms and jails, expanded mental health supports for students from early childhood through college, a diverse, well-supported workforce serving every corner of our state. Minnesotans are resilient, but resilience does not replace infrastructure. The impacts we're seeing today will reverberate for years. We urge the legislature to take these warning signs seriously and invest meaningfully in the mental health of all Minnesotans. Our communities cannot afford delay. Our neighbors, friends, family members, especially our kiddos, are counting on us. Thank you.
Thank you very much. Ms. Rickard, please state your name for the record and begin.
Thank you. Thank you, Chair Wickland and members of the committee. My name is Kate Rickard. I'm a licensed psychologist. I also get to work closely with caregivers and youth and systems across Minnesota as the Director of Quality Parenting Initiative Minnesota. I just have to say, wow, what a morning of information. There is obviously resonating lot of things that your committee is going to be tasked with this upcoming session, and a lot of what I have to say has been said already this morning, so I'm going to highlight the pieces that haven't been shared. From a developmental and public health perspective, the science is unequivocal. Children grow up in the context of relationships. Their brains and their bodies and their sense of self are shaped by the predictability, safety, and connection available in their caregiving environments. What has happened around us, particularly with the ICE activity, the threats to funding, and the climate of fear in our communities, is having a direct impact on their development. From the Circle of Security framework, we say that parents are the hands that hold the child. They are the secure base from where they explore their world and the safe haven from where they return for comfort, protection, and reassurance. When those hands are threatened, destabilized, or forcibly removed, the child loses not just a caregiver, but the architecture that supports healthy development. This references to Circle of Security Parenting, which is a parenting program steeped in evidence-based research that promotes caregiver understanding of a child's sense of safety and emotional development. What I want to offer to you is a parallel that you as the legislators are the hands that are holding our communities. Your decisions create the conditions in Minnesota's children that will either help them thrive or struggle. When federal actions create fear, instability, and separation, our state systems must respond with clarity, compassion, and protective policies that will buffer our children from harm. Because without intervention, the consequences will not be short-term. We are talking about generational impacts. This is increased trauma exposure, higher rates of mental and physical health challenges, disrupted education, we're already seeing that, and long-term economic and social costs that have been talked about today that we can look at for potentially decades without intervention. But the reality is we're not powerless. Minnesota has a history of leading with our values, safety, dignity, community. You have the opportunity and the responsibility to act as the stabilizing hands for our families who are being shaken by the forces outside of their control. Children need their parents' hands. Families need our community hands, and we're seeing that happen. And right now, Minnesota needs your hands, the hands that are steady, compassionate, and unwavering to be able to protect the well-being of every child who calls this state home. So I want to say thank you for your time, your commitment, and what is coming ahead in this legislative season for you.
Thank you very much. Welcome to the committee. Please state your name for the record and begin.
Yes, good morning, Chair and members of the Health Committee. My name is Haben Gebrgergish. Johannes is actually my middle name, so I apologize for the error there. I am a licensed teacher and mentor in the Twin Cities, working primarily with young people in St. Paul and Minneapolis, and I also co-lead the youth ministry at High Praise Ministries Destiny Center, walking alongside young people both in the broader community and within our church. And so, I stand before you as not just an educator, but someone who deeply loves our young people and believes in their brilliance and their potential. Right now, many of the youth that I work with are not feeling hopeful about the future. They tell me that they feel like the world is ending. They do not feel safe. They're constantly nervous. For some students, simply going to school feels like a risk, and they worry about whether their family members or their friends will make it safely through the day amid heightened federal enforcement and the growing presence and fear surrounding ICE activity in our communities. Our Minneapolis youth in particular, whom I work with, have endured profound trauma in just this last year, witnessing, the shootings of elected officials, the mass devastation of the mass shooting at Annunciation Catholic School, and now layered on top of that is the fear of federal immigration enforcement escalation. This cumulative stress is heavy. I can see it in them. It sits with them in the classrooms, in the buses, in the hallways. We know children cannot learn when they do not feel safe, and safety is not just physical, it's emotional, it's psychological, and it's the assurance of knowing that your family will be there when you get home. At this time also, many high school students feel a growing sense of financial pressure to support their families as access to critical services, including SNAP, becomes more uncertain. So they're also carrying adult burdens while trying to be children. As someone who grew up in the Twin Cities, feeling stability and opportunity, I weep for our young people who do not feel that same sense of security today. They're not really asking for much, they're asking for hope and safety. And so I urge you in this session to consider the real human impact of federal cuts and enforcement policies on the health and well-being of our young children, and to invest boldly in programs and protections that restore stability, joy, and hope to their lives. In particular, I urge you to support meaningful statewide investment in youth programming that reaches every young person across Minnesota. We need support that extends beyond a few communities and truly serves children in every corner of our state. And these programs should be robust and responsive to who young people are, not limited to traditional activities like basketball, but inclusive of leadership development, creative arts, career pathways, mentorship, faith spaces, and culturally relevant opportunities. And most importantly, they must be affordable and accessible so that no child is excluded because of cost or circumstance. Thank you for your time.
Thank you very much. Thank you, all of you. And we have just two more testifiers, Julia Martinez and Rachel Voigt. Thank you for coming today, and please go ahead and state your name for the record, and if you can keep it to less than 5 minutes, that would be great.
You got it. Also, thank you, Chair Wickland and members of the committee for being here today. My name is Julia Martinez. I'm a dietary aide at United Hospital here in St. Paul and a union member of SEIU Healthcare of Minnesota and Iowa. Prior to the Operation Metro Surge, my life was going well. I had moved out of the restaurant industry and had begun a wonderful new journey pursuing a degree in public health and working at United. Oh dear, please afford me my nerves.
Oh, don't worry about it. No,
thanks. On the night of January 27th at approximately 9:30 p.m., I'd finished my shift and was, I was leaving to drive home from the employee parking lot. As I left the lot, I noticed a strange car was following me. Soon after, another car got in front and boxed me in. Over the course of roughly 30 minutes, they tailed me closely. They sped up and slowed down erratically, but always coordinated their movements. They ran red lights and attempted to force me into oncoming traffic on Dale. Their actions appeared deliberate and with intentional intimidation. One of the vehicles had tinted windows and drove close enough to my rear bumper I couldn't see their plates. I was too frightened and distracted to reach for my phone. I cannot say for sure it was ICE because they never identified themselves and their cars were unmarked. Part of the terror was not knowing if I was being harassed by ICE agents or people emboldened by their presence. I don't know why they eventually moved on. Perhaps they got a look at me and realized I was too white to risk confronting. Although you have my last name. It felt like they had enough fun terrorizing a woman driving alone at night and were ready to just get their kicks elsewhere. Because I assume they have my license plate recorded, I've not been able to drive to work or around town without significant anxiety. I take the bus, or I walk, or I rely on friends for rides. We know ICE agents target hospitals, and I'm afraid they'll harass me again. I am not the only healthcare worker who has been intimidated by ICE. I began circulating a petition in my department to request our employer have better policies for protecting healthcare workers. As of today, I have about 50 signatures, and roughly 10% have reported being harassed by ICE. I've also noticed a significantly more people being absent from work. I put my plans to go to school for public health on hold. A large, diverse campus was another likely ICE target, and I cannot handle 2 high-risk factors in my life. Not only has ICE destroyed my peace of mind, they have stolen time I can't get back. I don't see how anyone can support federal government acting this way. Healthcare workers are afraid to go to work. Our patients are afraid to get care. ICE has made it harder for me to provide care and halted the education I need to better serve people. If you care about healthcare, please do whatever you can to hold ICE accountable and prevent them from hurting anyone else.
Thank you for your testimony. I'm so sorry that you had to experience that. I really appreciate your bringing your story forward.
Thank you.
Please go ahead and state your name for the record.
Thank you, Chair Wickland and Senators. My name is Rachel Voigt. I'm a certified professional midwife and the co-director of Roots Community Birth Center in North Minneapolis, and a member of the Minnesota Perinatal Access Team. The Minnesota Perinatal Access Team is a group of birth workers across many disciplines who came together in January of this year in response to community needs as a result of Operation Metro Surge. In the days following Renee Good's death, and with the increased ICE presence in the Twin Cities, we at Roots and clinics across the metro received numerous requests for home visits, home births, and help for families in need of health care. A group of midwives received a call from a mother who, in light of her partner's federal detention, had given birth in isolation, alone in her apartment with no medical care or family support. When she contacted us, she was 7 days postpartum, experiencing symptoms of sepsis and delayed postpartum hemorrhage. We were able to coordinate care across the cities to get her life-saving intervention at home. Shortly after this, we came together to create the Minnesota Perinatal Access Team, or MINPAT for short. Our primary focus has been resource navigation, and we created a 24/7 hotline that anyone can call with needs. In the last 6 weeks, we've had 10 to 20 calls per day from social workers, community members, care providers, and more. We have connected countless families with safe transportation in labor, transportation to the emergency room, to clinic visits, mutual aid, rent assistance, and home visits with our own clinics and other clinics throughout the cities. We've been able to fund this work through a rapid response grant through an organization that Roots has a relationship with, but we will run out of funding at some point and recognize the need for public health response to this in addition to our own grassroots efforts. The impact of Operation Metro Surge is ongoing and not yet measurable, but we know it has been detrimental to the safety of many. No one should birth in isolation. The fact that at least one, and likely more women, have delivered alone without family or access to reasonable health care and emotional safety in 2026 is alarming and inappropriate. We are a well-resourced state and a well-educated state, and perhaps more importantly, a state that cares about our neighbors. I've been both a midwife and a Minnesotan for 10 years, and I've never been more proud to be both. Thank you for considering the way in which perinatal health has been greatly affected by the federal presence in our cities and the way in which now we need great healing. Thank you.
Thank you very much. Thank you both. Members, we're running over, so we didn't have opportunity to have a discussion time, but if anybody wanted to make, Senator Mann, I don't want to cut things off, but we.
Thank you, Madam Chair. I can't not say anything. So I just want to recap kind of what we heard today because of the federal funding crisis that is coming our way. We're going to have childcare providers and daycare shutting down. Our property taxes are going to go up. Hospitals and clinics are on the verge of bankruptcy. Our healthcare infrastructure is being decimated. That's already happening. The system that keeps our water clean and our people healthy and our kids alive, that's all going away. People are going without health insurance, without food. People are going hungry. The destabilization of mental health, increase in suicidal ideation, which is something I saw personally in my ER. I had a young guy come in, ran his car into a tree, and said he would rather die than lose his entire family. Cuts of $1 billion to food per year, cuts of $1.4 billion to health care per year, affecting everyday people. And the quote I heard earlier today is, how do we even start to take a bite out of any of this? The destruction that is coming from the Trump administration that we have heard about from people in Minnesota today has been absolutely astounding. I don't know how anybody can sit up here and support any of this. I just don't. And the fact that we sat here last year and said all of this is going to happen, and the women, particularly of this committee, were called crazy and told we were overreacting, is now feeling so rich to me. I can't even wrap my mind around it. So I really just want to thank everyone who was here today providing your testimonies, because there's often a very big disconnect about what you say, about what is happening on the ground to real people, and what we hear sitting up here. And so I just want to say that you need to please keep on sharing, and we will keep fighting with you. Thank you.
Thank you. Any other members wish to make a comment, final comments? I want to also extend my thanks to all the testifiers, and I hope that, I agree, I hope you will continue to bring forward your testimony and your concerns and ideas, and it is, I'm feeling like this is a big responsibility that our committee has to make, to address concerns and try and preserve as much of the integrity of our systems as we can. But knowing that this is coming from a place of choices by our federal government, it is hard. So I appreciate your comments, Senator Mann. And seeing no other business before us, we are adjourned.